now we're going to use either our bracketing pliers, or you're going to use your cotton pliers to place the bracket on the tooth. And you can see the bracket. This is an upper left central incisor, because you've got the red mark on the distal gingival tie wing. And place it carefully on the tooth. And we're going to go over the rules of bracket placement in a little while. Push it against the tooth. You've got to use your instrument to push it right against the tooth, because you want to get all the excess material out. If you don't get rid of the excess material, first of all, the excess material will turn yellow, and you'll see that around the base of the bracket, which is not aesthetically pleasing. Plus, if there's too much material underneath the bracket, you're actually you could torque the tooth. You know, it's going to put a torque movement on the tooth, and that's not going to be good. So the minimal amount of bonding agent, have it come out, the excess come out all around the sides, and here we're wiping off the excess bonding material with our cotton pliers. You could also go in there with a cotton pellet, and you could wipe it off with a cotton pellet, whatever you want to use. But remember, you've put that on hard. You've placed that hard against the tooth. You can't just put it on there. You've got to push it hard against the tooth in order for it to stay on and for the bonding to be the most successful. Here you can see we're pushing against the tooth. We're pushing right against the tooth to make sure that bonding material is tight against the tooth, and making sure we wipe off the excess around the edge. Again, the red dot shows that that's an upper left central incisor. Now let's go over the cardinal rules for bracket placement, because this is key. I mean, the bonding procedure is extremely important, and that's why I'm going over this with you, but also to place the bracket in the correct position of the tooth is also extremely important. So cardinal rule number 1 is place the bracket correctly incisal gingivally. So what we do, we measure the distance, the length of the central incisor. So say that central incisor from the gingival margin to the incisal edge is 10 millimeters, 10 millimeters long. We find the midpoint, which is 5. So the midpoint is 5. We place the bracket on the central incisor ½ millimeter incisally. So if 5 is the midpoint, we move the bracket down ½ millimeter, and so therefore it would be 4.5 millimeters from the incisal edge to the slot. Okay, so the central incisor, again, measure the length of the central incisor from the gingival margin, here, gingival margin to the incisal edge. Take the midpoint, which is 5, and drop the bracket ½ millimeter incisally. And so it's ½ millimeter from the incisal edge to the bracket slot. Okay, so it's almost in the middle of the clinical crown, but it's ½ millimeter incisally. We do that for the central and the lateral incisor. The next thing we must do, the next cardinal rule, is the base of the bracket must be parallel to the incisal edge. So you can see the base of the bracket here is parallel to the incisal edge. Now, what if your incisal edge has mamelons? Well, you want to remove the mamelons. What if your incisal edge has a crack? The incisal edge is cracked. Well, you should restore it first. So do your restorative work first before you put the bracket. Remove the mamelons and make sure the incisal edge is parallel to the base of the bracket. So that's cardinal rule number 2. The cardinal rule number 3 is the bracket must be centered mesiodistally. You don't want the bracket too far this way or this way. It's got to be right in the middle. If it's not, it'll rotate the tooth. It'll cause a rotation. So if the bracket is too far mesial or distal, the result will be a rotation of the tooth. And we're trying to prevent rotations, not cause rotations. So make sure the bracket is centered mesiodistally. And you can see, here's the distal of the tooth. So the distal part of the bracket, the same distance from the distal part of the bracket to the edge of the tooth as the mesial part of the bracket and the mesial of the tooth. Okay? So that has to be centered mesiodistally, as I mentioned, or you'll cause a rotation of the tooth. So that's cardinal rule number 3. Cardinal rule number 4 for bracket placement is the bracket must be placed parallel to the long axis of the tooth. So find out the long axis of the tooth and place that bracket parallel to the long axis. Okay, so there's usually a scribe line right down the middle of the bracket, which is being covered up by this college plier now, and you can line it up. Also the wings of the bracket. So you can make sure the wings of the bracket, these wings of the bracket are parallel to the long axis. That's extremely important. If the wings of the bracket are not parallel to the long axis, they go on an angle like this, you will actually tip the tooth to the mesial or distal, and that's not good. So to prevent tipping, you have to have the wings of the bracket parallel to the long axis. So that's cardinal rule number 4. Wings of the bracket parallel to the long axis of the tooth. When you're placing brackets, it's a good idea to take out your mouth mirror, as you see here, and just check to see if the bracket is lined up properly, if it's placed properly mesial distally. Because sometimes, especially if the tooth is rotated, it's hard to see, and particularly in the bicuspids. I'm finding on bicuspids, you really have to use this mouth mirror to check from the lingual to see bracket position. Now you have 30 seconds working time with these. Okay, 30 seconds in which to change the bracket position and make sure it's just perfect. And that's quite a bit of time. If you go over the 30 seconds, you'll find that the bracket will be very difficult to move, and if you keep moving it, it will not, the bond will fail. So make sure you take your time, but you got 30 seconds of bracket. So that's lots of time to get it exactly in the right position. Again, here we are at the bonding procedure, and you can see here's prior to the brackets being placed, and here now all the brackets are on. The patient should wear sunglasses, the cheek retractors, the tongue aways, the saliva ejector, which is not in there now, and all the brackets are on. We have to wait now about 7 minutes for the brackets to completely set before we put the archwires in. So again, wait 7 minutes, setting time, remove the retractors, and then tie in the archwires. Again, if the teeth are badly misaligned, a lot of crowding, and remember we had that cuspid on the upper right, which was completely labally displaced, we're going to start with an 014 nickel titanium wire. And so just take the wire out, and they're all pre-sterilized, and then cut off the excess and then try the wire in. So we cut off the excess with the distal end cutting plier prior to putting the brackets on, prior to putting the wire in. Cut the excess wire off before you put the wire in, so you won't put it back too far and hurt the patient's cheek. Now, we usually don't place the molar bands or brackets until the next appointment. Now, if we're placing brackets on the tooth, this is not this case because she got bands placed, but if you're going to put a molar bracket, you can go all the way back. And actually, a lot of patients now are preferring brackets to bands. So if it's a boy and I'm concerned about his cooperation and eating hard foods, then I'll always put a band. But if it's an adult and she's very cooperative and will follow instructions correctly, then you can certainly put a bracket. But the bands obviously stay on better. And if you're going to be using cross elastics, of course, your advantage is to use a band because they got the lingual cleats on the lingual. Now we always have a mark on the archwire. There's a yellow mark on the upper archwire that goes right between the two central incisors. So you want to put that yellow mark right between the two central incisors. And we kind of put the anterior teeth in first. Children like the colors. So we have about 20 or 30 different colors of these elastics. They call them Sani ties. Some people call them donuts. Some people call them power O's. Whatever you want to call them, it's sort of elastic modules. The size we use is 1/20s, and we use an 018 hemostat with a hook. So the hemostat with a hook, it allows us to grab that Sani tie and place it on the tooth. Now I'm using, actually for the round wires now, I'm not figure eighting. This slide is a little older, this photo is a little older, and we were figure eighting all our cases now, but in the beginning. But now we're just doing we're putting that Sani tie or donut around all 4 wings of the bracket. Here we're doing a figure 8. Now, at the end of treatment, when the teeth are moved in the proper position, and we really want to sock that wire into the base of the bracket slot, we will do this figure 8 because we get more torque and more tip expressed in the bracket when we do that. So you can see, step 1 is you place the sani tie or donut around the 2 distal wings of the bracket. And then you, in step number 2, you slide that underneath the 3rd distal wing over here. And step number 3 or 4, step number 3, we move it up over that distal wing. And now it covers, it's sort of a, you can see it's kind of like a, it's a figure 8. We call it a figure 8, and we call it double tying, and that really socks that wire into the bracket slot. So as I say, now we don't do that because there's more friction created when you do that figure 8. There's more friction created. So now when we're doing round wires, we do it all around all 4 wings and no figure 8ing. But at the very end of treatment, if we want a little more torque and a little more tip in our rectangular wires, then we'll do the figure 8ing at the end of treatment once the teeth have been moved into the proper position. But when you put any figure 8 on there, you are definitely slowing down the movement of the case. But you're going to see that even with that figure 8, this case moved very quickly. Okay? One of the latest things in orthodontics is self-ligating brackets that don't have any of the ligature ties. The problem is that children really want the colors, and they really ask for these colors. And that's the most fun for them because every month they get a different color. So for the children, I usually just offer this. I offer this because they want the colors and they still move fairly quickly. You'll see this case corrected fairly quickly, and they're not self-ligating brackets. The other thing you've got to realize, when you figure 8 that elastic donut around the brackets, after 3 or 4 days, it loses almost all of its strength, and it's like a piece of spaghetti when it comes out. So it's really, it holds on initially quite firmly, but after a while it loses strength, and I don't think it slows it down that much, although it definitely slows it down more. There's more friction with this than there is with the self-ligating brackets, no question. Self-ligating brackets I would use on adults because adults don't want the colors. But I'm finding that most adults want the clear brackets. So let's see, here's the case. So you can see we've put the wires in. So I usually bracket from 2nd bicuspid to 2nd bicuspid, as you can see over here. I bracket from 2nd bicuspid to 2nd bicuspid. Okay, so here the brackets are all on. And you can see you put the bracket on the best way you can on the tooth that's lingually displaced, and later you'll re-bracket that tooth. And we've placed over here the blue separators. So the blue separators go in mesial and distal to the molars. So we've got the brackets on from 2nd bicuspid to 2nd bicuspid, upper and lower. The 014 nickel titanium wire, upper and lower, as you can see. Now those wires are very gentle, 50 grams of force. So the patients just had the brackets on. I really don't want them to experience any discomfort. The most they'd ever have to take is maybe an aspirin at night, but not a lot of discomfort, only 50 grams of force. Very nice appointment, probably in for 40 minutes. If you're a beginner, you might bring the patient in for an hour and spend a little more time and get those brackets on. Do 1 quadrant at a time. Probably start at the central incisor and go back on one side, then the central incisor go back on the other side, and then they do lowers and then do the other side. So do 1 quadrant at a time. Remember, only taking your activator out to do 1 quadrant at a time, because the activator can only be exposed to air for 10 minutes. After that, it loses its effectiveness. So it's a very pleasant appointment. Put the separators in, mesial and distal to the molars in the upper and lower, and bring the patient back in a week and put the molar bands on. As I said, the molar bands are a little more difficult, a little more pushing, a little harder in the patient than to put the little brackets on. Putting brackets on really is a breeze. Now, bracket position. Remember I told you, when we're placing brackets, rule number 1 was to measure the distance from the gingival margin, as you can see here, gingival margin to incisal edge, and then the slot is 0.5 millimeter below the middle of the clinical crown. And you can see the bracket placement in the central is the slot is 0.5 millimeter below the middle of the clinical crown. So that bracket is placed correctly on that upper left central incisor. Now the lateral incisor, however, I don't think we placed it correctly, because you can see if you measure from the gingival margin to the incisal edge, and the halfway point would be, say that tooth is 9 millimeters long, and the halfway point would be 4.5, then you drop the bracket 0.5 millimeter incisally, so you should have 4 millimeters from the incisal edge to the bracket slot, and you don't. So you can see plainly that that bracket on that upper left lateral incisor is too gingival and needs to be moved more incisally. So we'll have to see. We can put the brackets on and put the wires, and we get to the rectangular wires, you're going to see they may not like that tooth, they need to re-bracket that tooth. Okay, because that's incorrect bracket position. The cuspid is supposed to be placed in the middle of the clinical crown. So again, you measure from the gingival margin to the tip of the cuspid, and say that's 10 millimeters or 11 millimeters long, say it's 11 millimeters, then 5.5 would be the midpoint. And so you put the slot 5.5 millimeters from the cuspid tip to the bracket slot. So that bracket, I think, is correct. The bicuspids are also correct. What you do is, you, again, from the gingival margin to the tip of the cuspid, to the tip of the bicuspid, sorry, from the gingival margin to the tip of the bicuspid, measure, say that's 8 millimeters, and that midpoint would be 4. So you find the midpoint 4, and then go gingivally 0.5 millimeter. Okay, so the bicuspids are middle plus gingivally 0.5 millimeter up, and the centrals and laterals are midpoint and move incisally 0.5 millimeter, and the cuspids in the middle. So really, it's a very simple way to put brackets on. But remember, all those cardinal rules I told you are very, very important. But if you don't get one bracket on correctly, don't worry about it, because you can always change the bracket. Here you can see now we've placed all the wires here. And you've placed the separators, mesial and distal, the molars. And the lower, again, you've placed the brackets from second bicuspid to second bicuspid, and you've placed the separators, mesial and distal, the molars. And you're going to bring the patient back. You can see the separators over here. You can bring the patient back, and you're going to place the molar bands in a week.